Good morning, everyone. I'm Dr. Asim Hussein, and I'm delighted to welcome you today. Today, we'll be exploring autosomal dominant polycystic kidney disease, or ADPKD. This is a comprehensive presentation where we'll cover the basics of the disease, its clinical features, diagnosis, and management options. I hope you find this session informative and engaging. Let's get started. All right, let's take a closer look at this case. We have a 42-year-old man presenting with hypertension and intermittent flank pain. These symptoms suggest something affecting his kidneys. His family history is notable because his father needed dialysis at age 58, which indicates a possible hereditary condition. The ultrasound findings show enlarged kidneys with multiple bilateral cysts. Now, when we see bilateral kidney cysts combined with a family history like this, the most likely diagnosis points toward autosomal dominant polycystic kidney disease. This condition is characterized by progressively enlarging cysts that typically develop in adulthood and often lead to hypertension and kidney failure over time. It's important to differentiate this from other causes of cystic kidney disease, such as autosomal recessive polycystic kidney disease, which usually presents earlier in life, or acquired cystic kidney disease, which is more common in patients on long-term dialysis. Similarly, simple renal cysts are usually isolated and not associated with this kind of familial pattern or kidney enlargement. So, in summary, the key points here are the age, the family history, the ultrasound findings, and the clinical presentation, all pointing toward autosomal dominant polycystic kidney disease. This illustrates how family history and imaging help us narrow down the diagnosis in cystic kidney diseases. All right, let's take a closer look at this slide. The correct answer here is D now. The key point to remember is that bilateral enlarged kidneys with multiple cysts are a hallmark feature. This means both kidneys are affected and visibly enlarged due to the numerous cysts forming within them. Additionally, a positive family history is a crucial clue. It suggests a genetic component, which is typical for autosomal dominant polycystic kidney disease, or ADPKD. Recognizing these features together helps us differentiate ADPKD from other kidney disorders. It's important to connect this to our overall theme of understanding hereditary kidney diseases, as the combination of physical findings and family history really guides us toward the diagnosis. Let's look at this question about factors predicting faster progression to ESRD in patients with ADPKD. The question asks, which genetic mutation is linked to more severe disease and earlier development of end-stage renal disease? Now, among the options, we have mutations in PKD2, PKD1, UMOD, COL4A5, and NPHS2. The key point here is that not all mutations lead to the same disease severity. Specifically, mutations in PKD1 tend to be associated with a more aggressive disease course, meaning patients with PKD1 mutations often progress to ESRD earlier compared to other mutations. This is an important concept because understanding the genetic basis helps us predict disease progression and tailor management strategies accordingly. So, for this question, the best answer is B, PKD1 mutation, because it's well established that PKD1 mutations are linked to more severe disease and earlier ESRD onset. Connecting this to the overall theme of our presentation, recognizing genetic factors is crucial in personalized patient care, allowing us to better anticipate disease trajectories and improve outcomes. The correct answer here is B now. Let's delve into why that's the case. PKD1 mutations tend to cause a more aggressive form of the disease, meaning the progression happens earlier compared to PKD2 mutations. This difference is quite significant because it impacts how we approach diagnosis and management. Essentially, patients with PKD1 mutations often experience more rapid decline in kidney function and may require intervention sooner. Recognizing these genetic distinctions helps us understand the variability in disease course among patients and emphasizes the importance of tailored treatment strategies. This concept ties into our overall discussion about the genetics of polycystic kidney disease and how it influences prognosis and therapy options. All right, let's take a closer look at this scenario. We have a 48-year-old woman with ADPKD, which is autosomal dominant polycystic kidney disease. She's experiencing a sudden, severe headache along with vomiting. Now, these symptoms are quite concerning and suggest a serious underlying issue. The question here is, which complication must we urgently exclude? The options are pituitary adenoma, subdural hematoma, intracranial aneurysm rupture, migraine, or temporal arteritis. Given her presentation, sudden onset of a severe headache and vomiting, this strongly raises suspicion for a life-threatening event, specifically a possible intracranial aneurysm rupture. In patients with ADPKD, there's an increased risk of vascular abnormalities, including aneurysms, especially intracranial aneurysms that can rupture abruptly. This is a critical point because a ruptured intracranial aneurysm can cause a subarachnoid hemorrhage, which is a medical emergency requiring immediate diagnosis and intervention. So, in this case, the most urgent condition to rule out is an intracranial aneurysm rupture. Understanding this helps us focus on the importance of rapid imaging and diagnosis to prevent catastrophic outcomes. Remember, the key here is recognizing how systemic diseases like ADPKD can predispose patients to vascular complications, and prompt action is essential. The correct answer here is C now. Let's delve into why that's the case. Autosomal dominant polycystic kidney disease, or ADPKD, isn't just limited to the kidneys. It has strong associations with intracranial baryaneurysms. These aneurysms are small, saccular outpouchings that typically occur at arterial bifurcations in the brain. The key point is that these aneurysms can rupture, leading to subarachnoid hemorrhage, which is a serious and potentially life-threatening complication. So, understanding this connection is crucial because it highlights the importance of screening for aneurysms in patients with ADPKD. This ties into the overall theme of recognizing systemic manifestations and risks associated with genetic disorders like ADPKD. Let's talk about when we should consider screening for cerebral aneurysms in patients with ADPKD. As you can see on this slide, the question is, which scenario warrants getting a screening MR angiography? The first option, all ADPKD patients routinely, might sound like a good idea, but in reality, we don't recommend universal screening for everyone. Instead, we focus on specific risk factors. The second option, only after ESRD develops, isn't ideal because aneurysms can be present before kidney failure. So waiting until ESRD might miss the opportunity for early detection. Now, the third option, a family history of intracranial aneurysm or subarachnoid hemorrhage, is very important. This family history significantly increases the risk for aneurysms, so screening in this case is definitely warranted. The fourth option, presence of hematuria, is more related to kidney issues rather than cerebral aneurysms, so it wouldn't be a primary indication for brain vessel screening. And finally, the presence of hepatic cysts doesn't correlate with cerebral aneurysm risk, so that's not a reason to proceed with screening. So the key takeaway here is that in patients with ADPKD, we should consider screening MR angiography particularly when there's a family history of intracranial aneurysm, or SAH. This helps us identify those at higher risk proactively, which aligns with our overall goal of early detection and prevention. The correct answer here is C now. Let's talk about why screening is recommended in certain cases of ADPKD. It's particularly important for patients who have a family history of aneurysm or subarachnoid hemorrhage, as these are serious vascular complications that can occur. Additionally, individuals in high-risk occupations, such as those involving heavy lifting or working at heights, may benefit from screening because of the increased risk of aneurysm rupture. Lastly, screening is also advised before major surgeries to assess any potential vascular risks that could complicate the procedure. Overall, these targeted screening strategies help us identify at-risk patients early and manage their risks proactively. All right, let's look at this case. We have a 36-year-old man with rapidly enlarging kidneys and a preserved GFR, which indicates that his kidney function is still maintained despite the growth. The question here is, which therapy can slow down cyst growth and also help prevent the decline in GFR? Now, among the options, we need to think about what has shown effectiveness in managing polycystic kidney disease progression. ACE inhibitors, for example, are often used to control blood pressure and protect kidney function, but do they directly slow cyst growth? High-protein diets can sometimes strain the kidneys, but aren't specifically proven to slow cyst progression. Tolvaptan has been shown in studies to slow cyst growth and preserve kidney function in polycystic kidney disease. Loop diuretics are mainly used for fluid management, but don't impact cyst growth directly. And NSAIDs, while useful for pain, can actually be harmful to kidney function if used long-term. So, given all that, the best answer here is C, tolvaptan, because it specifically targets cyst growth and helps preserve GFR over time. The correct answer here is C now. Let's talk about why that is. Tolvaptan, which is a V2 receptor antagonist, plays a significant role in managing certain patients with this condition. It works by reducing cyst growth, which is a major factor in the progression of the disease. By doing so, it helps slow down the decline in renal function. This targeted approach is especially beneficial for selected patients, where slowing disease progression can make a real difference in their quality of life. So, in the context of our overall discussion, tolvaptan is an important therapeutic option because it directly addresses the underlying cyst growth and renal deterioration. Now, let's look at this question about a patient with ADPKD who suddenly develops flank pain and macroscopic hematuria. This scenario suggests a complication related to the cysts in the kidneys. Among the options, the most likely cause is cyst rupture or hemorrhage. When a cyst ruptures, it can cause sudden pain and bleeding visible in the urine. This is a common complication in ADPKD patients, especially when cysts grow large or rupture spontaneously. Other options like renal vein thrombosis or glomerulonephritis might cause hematuria, but they usually present with different clinical features. Renal cell carcinoma could cause hematuria too, but it typically presents more gradually and isn't associated with sudden flank pain. So the key point here is understanding that cyst hemorrhage or rupture is a frequent and expected complication in ADPKD that explains the sudden pain and visible blood in the urine. This fits with the overall theme of recognizing complications in polycystic kidney disease. The correct answer here is B now. Let's talk about why that's the case. In patients with autosomal dominant polycystic kidney disease, or ADPKD, the most common reason for sudden, severe pain and blood in the urine is cyst hemorrhage or rupture. This is a critical point because it helps us understand the typical clinical presentation in these patients. When a cyst ruptures or bleeds, it can cause significant discomfort and hematuria, which are often the first clues pointing us toward this diagnosis. Recognizing this pattern is essential in differentiating ADPKD-related complications from other causes of acute flank pain. So, in summary, cyst hemorrhage or rupture stands out as the leading cause of these acute symptoms in ADPKD, making it a key concept to remember as we continue exploring the disease. Let's take a look at this question about polycystic liver disease, or PLD, in the context of ADPKD. The key point here is that this woman has massive hepatomegaly, which means her liver is significantly enlarged, but her kidney function remains preserved. Now, among the options, the most accurate statement is that PLD is estrogen sensitive and tends to be more severe in women. This is because estrogen actually promotes cyst growth in the liver, making the disease more prominent in females, especially during pregnancy or with hormone therapy. It's important to understand that, unlike some other cystic diseases, polycystic liver disease rarely leads to liver failure on its own. Instead, the cysts grow progressively, but typically don't compromise liver function severely enough to require transplantation in most cases. So, in summary, while polycystic liver disease can cause significant liver enlargement, it doesn't usually lead to liver failure and it is indeed more severe in women because of hormonal influences. Recognizing these nuances helps us better understand the clinical course and management of patients with ADPKD and associated liver cysts. All right, let's look at the correct answer here, which is D now. When it comes to polycystic liver disease, a key point to remember is that it's estrogen sensitive. That means that hormones like estrogen can influence how this disease progresses. It's also more common and tends to be more severe in women, which ties back to that hormonal connection. Another important aspect is that despite the presence of multiple cysts, liver function is usually preserved. So even though the liver may look quite affected, its ability to perform essential functions often remains intact. Overall, understanding these points helps us distinguish polycystic liver disease from other liver conditions, especially in the context of patient presentation and management. It's a good example of how hormonal factors can influence disease severity and prevalence. Now, let's look at this question about long-term follow-up in ADPKD patients. The question asks, what is the most common cause of death in these individuals? When we consider ADPKD, or autosomal dominant polycystic kidney disease, it's important to remember that while kidney-related issues are central, patients often face other serious health risks over time. Looking at the options, intracranial hemorrhage, sepsis, cardiovascular disease, liver failure, and renal cell carcinoma, we can see that some of these are more prevalent as causes of mortality than others. In fact, research shows that cardiovascular disease tends to be the leading cause of death in ADPKD patients. This is mainly because of the high prevalence of hypertension and vascular complications associated with the disease. So, when we think about long-term management of ADPKD, controlling blood pressure and preventing cardiovascular complications are critical. The correct answer here is C, cardiovascular disease, because it highlights the importance of addressing the systemic effects of ADPKD beyond just the kidneys. This point ties back to the overall theme of the presentation, which emphasizes the importance of a comprehensive approach to managing this complex disease. The correct answer is C now. Let's talk about why that's the case. Cardiovascular disease actually stands out as the leading cause of death in patients with ADPKD. This is primarily due to issues like hypertension and vascular abnormalities that are common in these patients. Hypertension, or high blood pressure, puts extra strain on the heart and blood vessels, increasing the risk of heart attacks and strokes. Additionally, vascular abnormalities can weaken the blood vessels, making them more prone to rupture or blockages. So, when we're managing ADPKD, it's crucial to pay close attention to cardiovascular health, because these complications are a major factor in patient outcomes. This connection really underscores how systemic the impact of ADPKD can be, beyond just the kidneys. Let's take a closer look at inherited cystic kidney disease. This condition is characterized by the development of multiple fluid-filled cysts in the kidneys. Over time, as these cysts grow and multiply, they can significantly impair kidney function. This progressive cyst growth often leads to end-stage renal disease, or ESRD, which is the point where the kidneys can no longer support the body's needs. Now, most of these inherited conditions follow an autosomal dominant pattern, meaning that only one copy of the altered gene from either parent is enough to cause the disease. One of the most common forms we see is autosomal dominant polycystic kidney disease, or ADPKD. It's important to understand this because it highlights how a single gene mutation can have a profound impact over a person's lifetime, emphasizing the importance of family history and genetic factors in kidney disease. This overview ties into our broader discussion of how genetic inheritance influences disease progression and management. Now, let's take a closer look at the genetics behind polycystic kidney disease. PKD1, which is located on chromosome 16, is associated with a more severe form of the disease that often leads to early end-stage renal disease, or ESRD. In contrast, PKD2, found on chromosome 4, tends to cause a milder form with a later onset of ESRD. These differences highlight how specific genetic mutations can influence the severity and progression of the disease. This falls under the broader category of autosomal dominant polycystic kidney disease, or ADPKD, which is the most common inherited kidney disorder. Recognizing these genetic distinctions is key because it helps us understand the variability in how the disease presents and progresses in different patients. It also emphasizes the importance of genetics in guiding diagnosis, prognosis, and potential treatment strategies. So, as we continue, keep in mind how these genetic factors are central to the overall understanding of polycystic kidney disease. Let's take a closer look at the renal features associated with autosomal dominant polycystic kidney disease, or ADPKD. One of the hallmark features is bilateral enlarged kidneys, meaning both kidneys become significantly bigger due to the growth of numerous cysts. This enlargement can lead to various issues over time. Early on, patients might develop hypertension, which is high blood pressure. This isn't just a coincidence. The expanding cysts can affect blood flow and kidney function, contributing to increased blood pressure even at initial stages. Another key point is hematuria, or blood in the urine. This often occurs when cysts rupture, releasing blood into the urinary tract, which can be alarming but is quite common in this condition. As the disease progresses, we see a gradual decline in kidney function, leading to chronic kidney disease, or CKD. This is a critical aspect because it underscores the progressive nature of ADPKD. Overall, recognizing these renal features helps us understand the disease course and emphasizes the importance of early detection and management to slow progression and address complications. Now, let's talk about some extrarenal manifestations that are important to recognize in autosomal dominant polycystic kidney disease, or ADPKD. These manifestations can affect various organs beyond the kidneys and are crucial for a comprehensive understanding of the disease. First, intracranial baryaneurysms are a significant concern because they can rupture and cause subarachnoid hemorrhage, which is a medical emergency. It's important to keep this in mind, especially in patients with a family history or suggestive symptoms. Next, hepatic cysts are quite common in ADPKD patients. They usually don't cause symptoms, but can sometimes lead to hepatomegaly or discomfort if they grow large. Moving on, mitral valve prolapse is another notable extrarenal feature. It involves the displacement of the mitral valve leaflets into the left atrium during systole, which can sometimes cause mitral regurgitation. Then, we have abdominal wall hernias, which tend to occur more frequently in these patients. These hernias result from weakness in the abdominal wall, and recognizing them can help in timely management. Seminal vesicle cysts are also associated with ADPKD, particularly in males. They can sometimes cause issues with fertility or be detected incidentally during imaging. Overall, these extrarenal manifestations highlight the systemic nature of ADPKD. It's not just a kidney disease. It can impact multiple organs, underscoring the importance of a comprehensive approach to diagnosis and management. Let's take a closer look at how the diagnosis of autosomal dominant polycystic kidney disease, or ADPKD, varies based on age. For individuals between 15 and 39 years, having 3 or more cysts in total, whether in one kidney or both, is considered diagnostic. Moving to the 40 to 59 age group, the criteria becomes slightly stricter. At least 2 cysts in each kidney are needed for diagnosis. And for those over 60, the threshold increases to 4 or more cysts in each kidney. When diagnosing, ultrasound remains the primary tool, especially because these age-based cyst criteria are well established. If the ultrasound results are unclear, or if we need more detailed information for prognosis, we often turn to CT or MRI scans. These imaging modalities provide a more precise picture of cysts and kidney structure. It's also important to note that genetic testing is rarely necessary in typical cases. Most diagnoses are made based on imaging and clinical criteria. Overall, understanding these age-specific thresholds helps us accurately identify ADPKD and plan appropriate management. Let's talk about management strategies for autosomal dominant polycystic kidney disease, or ADPKD. First, controlling blood pressure is crucial, and this is often achieved with ACE inhibitors or ARBs, which help protect the kidneys over time. Next, it's important to treat any complications that arise, such as urinary tract infections, kidney stones, or pain, to improve quality of life and prevent further damage. For patients with rapid disease progression, tolvaptan can be used as a targeted therapy to slow down cyst growth. Screening for aneurysms, especially in high-risk patients, is also essential since ADPKD is associated with an increased risk of aneurysm formation. When kidney function declines to end-stage renal disease, renal replacement therapy, like dialysis or transplant, becomes necessary. Overall, managing ADPKD involves a combination of blood pressure control, complication management, targeted therapies for rapid progressors, vigilant screening, and timely preparation for renal replacement therapy when needed. This comprehensive approach helps improve outcomes and maintain patient quality of life. Let's go over some key pearls about PKD that are important for clinical practice. First, the PKD1 gene is associated with a worse prognosis compared to PKD2, so identifying the genetic subtype can give us valuable prognostic information. Next, when a patient with ADPKD presents with a headache, we always need to exclude subarachnoid hemorrhage, as it's a critical and potentially life-threatening complication. Moving on, hepatic cysts are common in ADPKD, but it's important to remember that they rarely cause liver failure, so most cases are manageable. Most patients with ADPKD ultimately succumb to cardiovascular disease, which underscores the importance of managing blood pressure and other risk factors early on. Regarding treatment options, tolvaptan is a medication used to slow cyst growth, but it does have side effects. Namely, it causes polyuria and can be hepatotoxic, so regular monitoring of liver function tests is essential. In summary, understanding these points helps us better predict disease course, manage complications, and optimize patient care, keeping the overall theme of early diagnosis and targeted management at the forefront. Thank you all for your attention and engagement throughout this presentation. I truly appreciate your time and interest in these ideas. Remember, the key points we've discussed highlight the importance of understanding the core concepts and applying them effectively. I hope this session has inspired you to think differently and to take actionable steps forward. Once again, thank you for being part of this journey. I look forward to seeing how you'll apply these insights in your own work.